risperidone last time, and there are several formulation approaches that provide with extended release formulation. And that gives you really like only as few as like once every 6 months, the patients just need to go and receive an injection. And this also indicates, right? This also indicates, this is not only from, we're talking about this one, right? This is the, with hydroxy, which is the metabolite of risperidone, which is paliperidone. And then you have several different, in terms of the use, right? There is the QD formulation in terms of administration, once daily dosing, and that's not a prodrug. And then you have two other prodrugs that are using this with the palmitate attached, with the prodrug form of this drug molecule. So you have 16 carbons attached to it, and then it forms, was prepared as nano crystals, and depending on crystal size and the dose in every injection, right? So that's how they have the extended range of duration of action. So that's what we talked about last time, risperidone, managing the schizophrenic patients in terms of their symptoms. So the next drug molecule, and actually there are 3 more on this page. They are structurally, one of them, this one is very similar, right? On the left-hand side, it's almost the same, and including the linker, and the right-hand side differs by the rinse system, right? You do have a ketone, but then you don't have ketones on this side in terms of risperidone and paliperidone. So this is iloperidone. So iloperidone is well absorbed, and in terms of metabolic reactions, because of the ketone introduced on the right-hand side, so you do have reduction, while the others only have oxidation, because as I mentioned earlier, and also probably in the drug metabolism classes in the pharmacochem, right, there are only 3 functional groups that can be reduced metabolically, and this ketone is one of the 3 that can be reduced. So all the other metabolic reactions, most of them are oxidative reactions, and then of course you have the hydrolytic reaction, which is escalates hydrolysis. So structurally very similar to this one, belonging to the same class. If you're looking at this would be benzoisoxazole class. So also in terms of its mechanism, very similar, and I think I didn't specifically mention last time in terms of risperidone, and actually also iloperidone. So almost all second generation, except the last one that we mentioned, which is a new mechanism of action, they're all kind of introduce an additional mechanism in addition to dopamine blocking effects, right? So most of the drugs that we talked about in the first generation, they block D2 receptors from binding to dopamine. And actually, with the second generation, most of them would introduce serotonin effects. So we are looking at really serotonin antagonist activity at 5-HT2 receptors, and some of them may also introduce 5-HT1 agonist activity in these drug molecules. So it is believed the introduction of serotoninergic activity, mostly blocking activity, antagonistic activity at serotonin receptors actually help with the treatment of the negative aspects of schizophrenia. And also that help reduce the incidence of the extrapyramidal side effects, the movement disorders, the cardiac dyskinesia. But that doesn't mean the second generation antipsychotics do not have any of the movement disorder as a side effect. Some of them do. For example, risperidone is one of them that still have, but then relative to the first generation, the the incidence of these movement disorders are fewer and less as compared to the other ones, the earlier first generation. So this is true for both risperidone, paliperidone, and iloperidone, right? So structurally very similar on the right-hand side, and this added the reductive metabolism, which is, of course, also has an extensive metabolism that you would see in some of the other drug molecules. But in terms of administration, there is really not many other formulations or prodrugs associated with this drug molecule, so rather simple as compared to risperidone and paliperidone. So the next two drug molecules belong to, again, a similar class. On the left-hand side, right, you, instead of the benzoisoxazole, and you have sulfur and nitrogen in it, right? Instead of benzoisoxazole, now it's benzoisocyanazole, right? So iso, that means the heteroatoms are next to each other, right? Because it's 1, 2, so it's isocyanazole. If it's 1, 3, that's just cyazole. But in this case, the nitrogen and the sulfur next to each other are consistent. So these two are in the same category, right? And also the linker differs from the other one. Linker in the other two structures is piperidine, and this two structures you have piperazine, right? So still a 6-member ring, but it's just the carbon in here is replaced with a nitrogen. So you see it's bioisosteric replacement, and also the oxygen is replaced by sulfur here, so bioisosteric replacement, right? And you're seeing that you come up with new drug molecules in this category. So now with these two structures, again, they have not only activity at dopamine 2 receptors, blocking the binding of dopamine to dopamine 2 receptors. It also has the serotonin activity at 5-HT2 receptors as an antagonist, and 5-HT1A as an agonist. And also the other feature of these two drug molecules, the prazidone and also this residone, these two both have food effects in terms of their absorption. So actually taking the drug molecules with food can increase absorption, right? So this is probably what can help in terms of getting the drug molecules into the system. So it can be taken with food, so patients can get more of these drug molecules into the system. And both of these two drugs are indicated for schizophrenia and bipolar disorder. Schizophrenia and bipolar disorder. So this drug was approved in 2001, and this one, residone, was approved in 2010. So just about almost 16 years ago. So in terms of mechanism, very much similar, right? Among all 4 of these drug molecules, the addition of serotonergic activities, antagonist activities at 5-HT2, and the agonist activity at 5-HT1, and that probably helped treating the negative and the positive aspects, both positive and negative aspects of schizophrenia, and also help in terms of reduce the incidence of extrapyramidal side effects. So these 4 structures are very much the same in terms of only bioisosteric replacements. So the next 2 structures are also similar to the one that we looked at, the clozapine, right? Clozapine. So clozapine was the first, second generation or atypical antipsychotic, right? But then that drug is associated with a serious side effects. Serious side effect, which is agranulocytosis. Right? That's a serious side effect. That can be fatal if it's not treated promptly. But these two drug molecules, what you're seeing here, are at least the first one, olanzapine. The difference is you have the right-hand side, you have the sulfur containing Rin system replacing the phenyl ring. So that would be considered, again, a bioisosteric replacement. But even though it's a 5-member ring as compared to a 6-member ring, but phenyl rings and thiophene rings are considered to be similar in terms of its shape and electronic characteristics. So replacing those with each other can often give you similar activity. So this is olanzapine, and so this is a cyeno. So you can see this is cyeno benzodiazepine, right? So it's a benzene ring fused with a 7-member ring with 2 nitrogens in it. So this is cyeno benzodiazepine type of structure in this drug molecule. So this drug is similar to clozapine, treats also both positive and negative aspects of schizophrenia, while it does not have the incidence of agranulocytosis, right? So this is an advantage of this drug molecule. So this drug is also used for bipolar disorder, and this drug is known to have fewer Parkinson-like side effects, the movement disorders that you see with certainly first generation, and also less as compared to risperidone. Risperidone still has some of the movement disorders or side effects. So this drug produces very little sedation, right? Very little sedation. So this was approved in 1996. In 1996. So still a relatively good drug and also atypical antipsychotic. So half-life from 21 to 54 hours. So this is olanzapine, right? Structurally resemble clozapine, but then with the advantage of not having the agranulocytosis as a side effect. So the next drug molecule is also somewhat similar, right? Because at least the bottom part of it, so you still have the 2 benzene rings flanking the 7-member ring, but in the ring you have 1 nitrogen and 1 sulfur, right? So this is called thiazapine, not diazepine. Thiazapine, THIA, refers to that you have a sulfur substitute, a sulfur in the ring system. And you do have 2 benzene rings, so it's dibenzothiazapine. And you do have then the side chain on the top over here, which is similar, but then you do have longer side chain attached. So it's ethanol attached to another ethoxy for this drug molecule. So this is believed to be having both, again, effects on dopamine and also serotonin antagonist activity. That's what that leads to the drug can be treated for both positive and negative aspects of schizophrenia. So it's an atypical antipsychotic for the management of psychotic disorders, including schizophrenia. And because you have a sulfur in here, so there is a chance of this drug molecule being oxidized, right, in the air or metabolically to sulfoxide, or and also you have a primary alcohol at the end here, so that can be oxidized to give you carboxylic acid. And oxidation either here or here on the sulfur would lead to inactivation of the drug molecule. So this can be just predicted based on the structure of the drug molecule. So these 2 and these actually resemble clozapine, right? Some of the replacements with the nitrogen being replaced by sulfur here, or in this case, the carbon, like the double bond, carbon-carbon double bond in the benzene being replaced by the sulfur that gives you the thiazine. So the next three drug molecules, and actually coming back and resemble to what we have seen on the last page, you can see you have an aromatic ring on the left-hand side, and then you have a piperazine linker, and then you have an alkyl ether, and another aromatic ring on the right-hand side. So the first one here is aripiprazole. So aripiprazole, the trade name is Abilify. So this is a drug was approved in 2002. So this drug is used to treat schizophrenia, bipolar disorder, and also Tourette disorder. So the drugs in this case, and probably with the other drugs as well, so they do often require some time, right? Because we're talking about central nervous system, the receptor system, just like in the treatment of depression, and the drugs may take some time to achieve a balance, right, in the central nervous system in terms of neurotransmission. And they may take, for example, this drug may require 1 to 2 weeks of administration before the effect is seen in patients. So the drug can be administered once a day. In terms of its mode of action, it's known to be a partial agonist at D2. So partial agonist at dopamine 2 receptors and also 5-HT1A, right? So when we say 1 or 1A, we are talking about agonist activity. In this case, it's a partial agonist at D2 and 5-HT1A. So this means that it's not fully, right? So a full agonist. So also antagonist activity at 5-HT2A, specifically at this drug molecule. So you probably noticed that this drug molecule has lactam on the right-hand side, right? This can be polymerized, but then you throw hydrogens on these two carbons, and actually this can be removed by 2 hydrogens to give you the double bond. So removing hydrogens from the drug molecule is still considered oxidation, right? So oxidation, that means you add oxygen to the drugs or you remove hydrogen. If you add hydrogens to the molecule, that's reduction. So in this case, it can be oxidized to give you dihydro, dihydro. So that means removing 2 hydrogens, and that's still an active metabolite. So that's the drug on the next, under this, brexpiprazole has, right, with the double bond. So that will still give you an active metabolite. So the other metabolic reactions, dealkylation, and you can also have, so this is say one metabolism, so this is the second metabolism. Of course, the first one is going to give you probably inactivation because the molecule is kind of cleaved right in the middle. And then the third one would be oxidation. We're talking about hydroxylation on the aromatic rings here. So it's rather of this drug molecule in terms of absorption is pretty high, 87% oral bioavailability. So the half-life of this drug molecule in terms of the parent was 75 hours. So that's very long half-life, right? So then, in terms of the active metabolite, number 2 here is active. that has a half-life of 94 hours. It's even a little bit longer. So Abilify, initially when it's approved, it's really a drug that can be taken once a day, a dose once a day. And there is a prodrug form, because what you see here, right, so this is the nitrogen H that can be replaced by a methylene, and then you attach to an oxygen, and then you have ester that attached to a fatty acid. So in this case, it introduced CH2, right? So you have, say, 10 here, and then plus CH3. So this is what's called aripiprazole noroxol. So this is the prodrug. So in addition, prodrug, of course, can be administered as, this is the trade name, Ristada. So this is a drug with a 12-carbon fatty acid attached to it, right? So once it's administered and the prodrug gets into the blood, the ester is going to be hydrolyzed right here, and what's left on this one would be hydroxymethyl attached to the nitrogen, which is just going to fall apart to give you formaldehyde and the parent drug molecule. So that will give you basically long duration of action. In this case, it's a lipid-soluble prodrug that's going to be prepared in what's called sterile emulsion, right? So you have an oil layer and you have a water layer, aqueous kind of suspension with drug, of course, dissolved in the lipid, the oil portion of it, right? So that's an emulsion. So that can be injected into the patient's system, like say once 4 to 6 weeks. So that would help manage the schizophrenic patient in terms of the application, in terms of this drug molecule. So this is aripiprazole noroxol, right? So there is also actually an aripiprazole I should have mentioned earlier, is aripiprazole. Aripiprazole maintainer. That's also an extended release formulation. So in that formulation, it's actually used the parent drug molecule. It's called maintainer. So parent drug molecule in a micron particle size, and they're suspended, I think, in aqueous solution. So in this case, the patients can also go and receive the injection once a month, I think, or once a month in terms of monthly injection through IM, right? So you can have aripiprazole maintainers, so there are 3 different kind of forms of this drug molecule. So you have the parent drug molecule, then once a day dosing, probably a tablet or capsule form, and then you have the aripiprazole maintainer, which is just the parent drug molecule in a micron particle size, and then suspended in aqueous solution, and then after injection, it will slowly kind of dissolve and leak out into the from the injection site. And then you have the prodrug form, is aripiprazole noroxol, which is then sterile emulsion that can give you basically the drug molecule over an extended period of time. So injection also for intramuscular injection. So this is aripiprazole. So this is a drug that was marketed by BMS in 2002. So the next drug molecule is brexpiprazole. So the difference, right? So on the right-hand side, now you have the double bond. We know that with the double bond here, it's an active metabolite. So this is kept, right? Was similar to an active metabolite. So on the left-hand side, the dichloro on the benzene ring is replaced with a thiophenol ring system that's fused. So this is brexpiprazole. So this drug molecule has now a half-life of 91 hours. So this is mechanism-wise very similar to just aripiprazole, the same type of receptors, partial agonist at D2 and 5-HT1A, antagonist at 5-HT2A as the mechanism of this drug molecule. So oral bioavailability is similarly high. So in terms of the oral bioavailability here, it's 95% of the drug is absorbed for this brexpiprazole. So this is used as antipsychotic. So in terms of indication, and it uses for MDD, right? So this is a major depressive disorder, for schizophrenia, and also just, I think in like a little over a year ago, it is also approved for agitation in Alzheimer's. So agitation, Alzheimer's, dementia patients, right? So when these patients, so this is a brand new indication. So that may also indicate some of the earlier drug molecules that are used for just schizophrenia might also be used in this case. But at least this drug has been tested and proven to have clinical efficacy in terms of treating or managing the agitation in the Alzheimer's patients with dementia. So this is the brexpiprazole, with the new indication that was just approved in 2023. So the next drug molecule, you can see on the left-hand side, very much the same as aripiprazole. You have the dichlorophenol ring system, you have the piperazine. And on the right-hand side, in this case, you just have a cyclohexyl ring. Instead of the aromatic ring earlier, it's just having cyclohexyl ring, and it doesn't have the oxygen, the ether, that you see in the earlier two drug molecules. And then you have a urea on the right-hand side. Right? Carbonyl on both sides, you have a nitrogen and urea. So you have dimethyl amine, dimethyl on the nitrogen on one side of the urea. So that indicates the methyl groups can be removed. So that will give you still similar, like still urea. So it's still, they're considered active metabolites after the methyl is removed, because the methyl itself, in this case, doesn't really do much. But then if you remove it, you still have ANH, electronically very similar to the parent drug molecule. So the advantage of this drug molecule, the half-life is 2 to 4 days in patients, 2 to 4 days. So this drug was approved in 2015 for schizophrenia, bipolar disorder, and also MDD. So in addition to the schizophrenia, bipolar disorder, so this drug is approved for MDD. So in terms of its mechanism of action, again, similar to what you've seen earlier, so it's a partial agonist at D2 and 5-HT1A receptors, and then antagonist at 5-HT2A, and also in this case, it says 5-HT2B, also an antagonist activity for this cariprazine in this drug molecule. So the trade name in this case is Virela, right? So this is the drug that's being used in the clinic. More drugs available in the market. So this drug is protected by patents until 2029. So you still have several years before, 3 years before this patent expires, before the generics get come to the market. So this is the drug molecules that have like structurally similar, right? You can see aromatic ring, you have 6-member ring, and then you have another functional group on the right-hand side. So the next page have a few more drugs, actually 3 more drug molecules. One is acenapine or Stepharis. Acenapine is actually a mixture of 2 isomers. So you can look at this, you have a mixture of 2 isomers, so you have mirror image of these 2. These are kind of used in the drug molecule. So this drug was approved in 2009. So structurally resemble in terms of mianthropine. So this is a mianthropine. This drug is used as antidepressant in Europe, not in the US, but it's a drug used as an antidepressant. But we did cover this mirtazapine, right, as an antidepressant that's used in the US. So there are some similarities between certainly these 2, right, and then you have the difference here is just another nitrogen in the pyridine system. And structurally, from here to here, you have added oxygen, and you have basically shrink the ring from 6-member ring to a 5-member ring system. So acenapine with a mixture of 2 enantiomers that's used in a clinic. The treatment for this drug molecule is used to treat acute manic and mixed episodes associated with bipolar disorder and also schizophrenia, right? So bipolar disorder and schizophrenia. So it's an atypical antipsychotic with probably dopamine and also serotonin antagonistic activity. So the administration of this drug molecule is a little bit different as compared to the other one. So this drug is actually sublingual tablet. So it's a sublingual tablet. So patients just going to be placing this under their tongue and to allow it to completely dissolve. So it's not kind of swallowed, right? So to dissolve. So in this case, they don't get absorbed through the GI tract, right? This way we can avoid first-pass metabolism because the drug, if it's absorbed, if it's swallowed, it will go through the GI tract. The first organ it goes to is the liver, right? That's where the metabolism happens with this drug molecule. So this is a sublingual tablet, so that you can avoid the first-pass metabolism. So this is the acenapine. So the next drug molecule structurally resembles to what we have really discussed before, right? So if you look at this, you have para-fluorophenol, you have a ketone, you have 3 carbon to the linker. This is butyrylphenol, right? So this is butyrylphenol, but this is a very new butyrylphenol. So this is a drug that was approved in 2019, so just about 6-7 years ago. With the right-hand side, the butyrylphenols that we've seen before, right? So you have a 6-member ring similar to this, and then you have an aromatic ring. There are some similarities to that, but this is a more complicated tetracyclic ring system. Okay? Because of this complication, this complicated structure, this is actually considered to be a 2nd generation. So this is the newest butyrylphenol considered to be atypical. So if we say all butyrylphenols are typical antipsychotic, it's no longer true, right? Butyrylphenols, and this new one here is also a butyrylphenol, but it also has antagonistic activity 5-HT2A, in addition to at the dopamine receptor. So this is a drug used once daily dosing, and the metabolic reactions can happen by cyclopamine P450-3A4, and you can have, this is similar, right? So you can have reduction. So you can have this to give you the alcohol, so that's reduction. So you have both reduction. On the right-hand side, you're going to have oxidation. You probably can also cleave this off. It's oxidative metabolism. So this drug molecule is metabolized by cyclone P450 to about actually 20 plus different metabolites, okay, by cyclone P450. And this drug, there is, basically says you cannot drink grape juice, grapefruit juice. Why grapefruit juice? Right, so you have inhibitors of cyclone P450 in grapefruit juice that can probably extend the half-life of this drug molecule. So this is contraindicated. So basically you cannot drink, patients cannot drink the grapefruit juice when they're taking this drug molecule. Otherwise, their serum concentration can increase too high and cause problems. So this is a second generation butyrylphenol, right? Second generation butyrylphenol. It's working on, because of the complicated structure over here, so it added the serotonin antagonist activity 5-HT2A. So that's one of the additional binding probably that can happen with this drug molecule. Now, this is a new combination that was just approved. We're talking about this drug molecule that approved by FDA only in 2024. Cobenfy, right? So this is actually a new mechanism as compared to what we have seen before, right? What we've seen before, we are working on dopamine receptors, we are working on serotonin receptors, but in this case, it's a combination of two drug molecules. It's xanomeline, right? So this is the drug molecule, and you probably, I don't know whether you've seen it before in Dr. Wang's lectures. Did he cover this one? Probably not, right? So, but this is a muscarinic receptor agonist. So this is a tertiary amine, and this part of it is mimicking the esters in acetylcholine. So this drug actually binds to acetylcholine receptor. So in this case, it's called M1 and M4 receptor. So it's muscarinic receptor agonist. And this, of course, we're referring to these receptors in the central nervous system with the muscarinic receptor agonist. So when these drug molecules bind to get into the central nervous system, this is an alkyl chain, right? You have 6-carbon alkyl chain. So you provide lipophilicity so it can cross the blood-brain barrier. So that's required. So this is mimicking the positive charge in acetylcholine, but then in this case it's tertiary amine, so when it's free, so it can permeate across the blood-brain barrier. So this is mimicking the esters in acetylcholine. So with the M1, it's believed to improve cognitive functions and improve also the negative aspects of schizophrenia. Okay? With the M1, what M1 is doing, cognitive function. And then the M4 in the central nervous system actually improves the release of dopamine. Oh, so want the less dopaminergic activity, right? So this is actually decreased dopamine release once M4 is activated. So what we are seeing is you have a combination of two effects, right? You decrease the dopamine release in the central nervous system, and that improves the positive aspects of schizophrenia. The positive and the negative aspects. So it treats both positive and negative aspects. So this drug certainly doesn't have the movement disorder that you usually see in first generation of antipsychotic or some of the second generation ones. But it does have side effects of these drug molecule combination. So it can have GI side effects and also have cardiovascular side effects. GI, we're talking about nausea and vomiting, and also indigestion, and also constipation that can be related to the activity of these drug molecules. Cardiovascular, we're talking about increase in blood pressure and increase in heart rate, maybe causing tachycardia. And now, I have not mentioned the other component of this combination, right? So what is this right-hand side doing? This is trospium. Trospium, first of all, is a quarterly ammonium cation, just like acetylcholine, right? Acetylcholine has a positive cation. It does have an ester, right? So it's mimicking acetylcholine. Because the charge is permanently there, this drug doesn't get into the central nervous system. So it stays in the periphery. That's what we want the drug to do, to counter the agonistic effects of this drug in the periphery, right? Because this drug is given orally. It's going to be in the periphery, it's going to go into the central nervous system. In the periphery, the effects is going to be muscarinic receptor agonistic effects, but we don't want it in the periphery. We only want the effects in the central nervous system to treat the both positive and negative effects of schizophrenia. So the drug molecule, this on the right-hand side, is a muscarinic receptor antagonist. And this antagonist will occupy the receptors that this molecule might bind in the periphery. So it doesn't have less, at least, of the peripheral effects. Right? So this is why this combination has been very beneficial for patients. Right? It's a very new way of treating schizophrenia. So this is approved for schizophrenia in adults. So this is what this combination, Cobenfy, is used to treat. So the mechanism-wise, although some literature says it's still very hard to understand, unknown, but it's related to these pharmacologic effects on M1 and M4 muscarinic receptor agonist activity of this drug molecule in the central nervous system. But the effect in the periphery of this drug molecule is lessened, reduced by use of this drug molecule, which is confined to the periphery. Right? So the antagonist activity will counter the effects of this drug molecule in the periphery. So we are only using the central nervous system effects of this drug molecule. So this is what I want to talk about in terms of antipsychotics, right? So you included the new ones. So I'm going to start a little bit, at least, on the anti-epileptic drugs, and also referred to as anticonvulsants. So what is epilepsy? Right? Epilepsy basically is a chronic condition that's characterized by recurrent seizures. What are seizures? Seizures basically episodes of dysfunction in the central nervous system in the patient's brain, and that can cause abnormal discharge of these neurons, of cerebral neurons. So there are different kinds of seizures, and you see partial, you have partial seizures, so that means seizures only start, and also start from that one hemisphere, because our brain, central nervous system, is divided into the two hemispheres. If it's starts from one hemisphere of the brain and involve jerking of the extremity only, probably mostly on one side, right? So that controls one side of the brain. And the period of the seizure that lasts is usually about a minute to a minute and a half. So we're talking about 60 to 90 seconds. And patients may lose or may not lose consciousness during this process, right? So this is for partial seizures. So it originated from half of the one side of the brain. And then you have generalized seizures. That means the whole body is involved, and the origination of the seizures from both sides of the central nervous system, both hemispheres of the brain. So among this, and you see, usually consciousness is impaired for the generalized seizures. So you have two types. One is called grand mal seizures. Grand mal seizures, also referred to as generalized tonic-clonic seizures. So this is sudden loss of consciousness. Again, this is whole body, right? Consciousness lost, and general muscle spasms last in 2 to 5 minutes, longer than the partial seizures. 2 to 5 minutes. And then you have petit mal seizures, also referred to as absent seizures. In this case, the seizures, when it's happening, still occurring from, originating from both the hemisphere, and also it lasts shorter, right? You have 5 to 30 seconds for each episode, but then there are many of these episodes linked to each other. The brain may not have time to recover in these cases, right? So they can occur multiple times during the day. So when this happens, right, can be particularly disabling and more common in children than adults. So this is the petit mal seizures, right? So you have multiple episodes of these seizures. Even though it's shorter, right, you have multiple episodes can happen in one day. So these are petit mal seizures. And then there is also a very disabling or an emergency situation when this happens. It's called status epilepticus. Status epilepticus is a condition marked by a single prolonged seizure lasting more than 30 minutes. Like the other ones that we mentioned, usually probably 5 minutes, the longest. In the grand mal seizures, 2 to 5 minutes. But in this case, it lasts for more than 30 minutes, or insufficient time between multiple seizures that happen in between, like the patients just didn't have enough time to recover. Right? So this is emergency situation when this happens, and drug molecules to treat status epilepticus needs to be given by IV administration, so it can be done quickly to control the conditions. So the mechanism associated with different types of seizures can be different depending on patients. So that's another complexity of the epilepsy, right? So drugs that you'll see in this category are relatively old, so they're not very good, associated with more side effects. And also these patients may respond. Some of them may respond to one type of drug, and some of them don't, and they may respond to a different kind, because the mechanism causing the seizures are different, right? So there could be GABA involved, and there may be others involved. So the strategy in controlling the seizures is one, to increase CNS inhibition, right? So that means you increase GABA. So in GBA here should be GABA, add an A here, okay? So you should be able to increase the synthesis of GABA, so you have more of the inhibitory neurotransmitter, or you decrease the destruction of GABA, so that means you can have more in the synapse. And you can also potentiate the action of GABA at its receptors, like barbiturates and also the benzodiazepines. So you'll see some of the benzodiazepines and also some of the drugs that mimic the actions of barbiturates. And then you can inhibit the excitatory neurotransmitter neurotransmitter, that's the glutamate receptor. So that means glutamate binding to its NMDA or MPA receptors, then you can inhibit, you can use antagonists at these receptors so the CNS excitation can be reduced. So this is the strategies for controlling. So I just mentioned when you have drug molecules, you see the drug molecules are rather small and simple. So you can see that you have 5 membranes, right? You have, this is succinimide, these succinimides, because it has 2 carbonyl, 1 nitrogen in the middle, and here you have another methyl group on the nitrogen. So that would be a site of metabolism. You can remove the methyl. Once the methyl removed, it's similar to this one, so you have an active metabolite, right? Similarly is this one. This is oxazolidine diones. So that means you have oxygen, you have a nitrogen in the ring system, and you have 2 ketones, 2 CO double bonds. And then you have 3 methyl groups. So trimethadione, right? So all 3 of these drug molecules were approved in the 1940s and 50s, right? So we're talking about 70 years ago, these drugs were used and approved. And of course, these drugs are all used for absence seizures or petit mal seizures, right? So this is under the category for petit mal seizures. And they're often associated with side effects. So they're not usually, actually the drug on top over here, ethyl succinimide, and this is with a methyl group attached to it. This is actually better in terms of its side effect and profile, and that can give you a better choice in terms of treating the diseases. So the activity of these drug molecules, they just kind of go into the central nervous system and depress the CNS and decrease the responsiveness to the stimuli that cause seizure. So it doesn't really say much, but it's just saying these drugs are going to the central nervous system and blocking and slow down basically the central nervous system reactivity to these stimuli. So with the methyl groups, they're going to be metabolized on the nitrogen to remove the methyl, so that will give you shorter half-lives. But without the methyl, and this actually have relatively longer half-life. So this is about 30 hours in like infants, like small children, but then with larger children can be longer, double the half-life. So these drugs are not very good, right? So there are better drugs nowadays, and for this drug, for example, it has toxicity issues and can cause problems with skin, also with fetal malformation. So that means with pregnant women, you probably don't want to give drugs to patients like that. So, for example, using this drug, because the side effect is so much, the blood needs to be monitored in terms of counts and so on. So this is not very good drug. So we will talk more about the anti-epileptic drugs next time.